point of contact for majority of the women for various problems, not just the gynec problems, but also the breast problems. So I feel it becomes our responsibility to take every opportunity to educate these women as well as to screen these women for the breast cancers. That's why this webinar is being conducted, which will provide the right approach to the screening and the early diagnosis. So let us start the session by virtual inauguration. Yes.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you. Now I request Dr. Lalita, Chairperson Breast Committee Kasoga, to formally welcome our guests.
Yeah, thank you. Thank you, Dr. Shipra. And ma'am, sir has said I'm traveling by flight. So if possible, I'll join at the end.
Okay.
So breast cancer is most common cancer to affect women in the world and in India. 1 in 3 to 1 in 8 women are affected by breast cancer. About 40% of world's breast cancer occur in India. More than 2 lakh women are diagnosed with breast cancer every year in India. 76,000 deaths were reported in 2020. It is likely to rise every year. So we have a very big responsibility in not just reducing the mortality, but also the fear associated with it. This webinar is organized to serve this purpose. I welcome Dr. Vidya Tobi, President Kasoga, who is always encouraging us to conduct webinars. She always says, "You're not alone, we are all together doing this." Thank you, ma'am, and I welcome you, ma'am. I also welcome Dr. M.G. Hiremat, Chief Patron Kasoga, who is a visionary. He started breast committee not just in Kasoga, but also in Foxy. So he saw this day, that day itself. I welcome you, sir. I also welcome Dr. Rajashri Palladi, Secretary Kasoga, who is always a positive support to all of us. I welcome you, ma'am.
Thank you. Thank you.
I welcome Dr. Suman Gaddi, Treasurer Kasoga, ever smiling and ever supporting to us. I welcome you, ma'am.
Thank you. Thank you, ma'am.
Today's webinar's key persons and vibrant national speakers: Dr. Charulata Bapai, Chairperson Foxy Breast Committee, and Dr. Rohit Kumar, Senior Consultant Surgical Oncology at Astor Institute of Oncology. I welcome both of you, and we are eagerly waiting to listen to you.
Thank you.
Welcome you, ma'am.
Thank you. Thank you.
I also welcome Dr. Durga Das Kasoga, who is a steel pillar of My Mother Society, Tumkur Society of Obstetrics and Gynaecology. I welcome you, sir. I also welcome Dr. Jyoti, President TSOG, who has not only attended, but also has urged all the members of TSOG to attend today's webinar. I welcome you, ma'am. I also welcome zonal coordinators. I welcome all the chairpersons of all committees. I also welcome presidents, secretaries of across Karnataka, all societies. And I also welcome wholeheartedly members of various societies and delegates of today's webinar. I now request Dr. Vidya Tobi, President Kasoga, to present presidential speech. Dr. Vidya Tobi.
Yeah. Thank you. Thank you very much. And really, I must congratulate our both committee chairs
Thank you, ma'am.
for this very a nice program, and we all know that the October is cancer awareness program. We are arranging tomorrow a walkathon and cancer awareness program at my place in Bijapur. And I request all of them, not only October month, I think we should take interest. We should take the awareness programs to all the societies, not only all the societies, but even we should give the write-ups in the newspaper. You should have a radio talks so that people come across the Karnataka, they should know what is going on. So OBGYNs, they play a very significant role across the spectrum of cancer awareness, I must say, from not only cervical endometrial cancers to the breast cancer. Every gynecologist has an opportunity to palpate the breast of the woman, and they always never do this. I know that most of them then they never put the speculum also if you do the survey. So if the patient comes in for white discharge, they will just give the symptomatic treatment. I have seen, and I have at the periphery, we did a small survey. So most of the patients are also reluctant to have a speculum examination. Likewise, the gynecologist should definitely palpate the breast so that they will find out some lump, something like that. And all gynecologists should have the training as far as possible for the identification of potentially malignant breast nodules. So they must differentiate between fibroadenoma, fibroadenosis, or if it is hard, then definitely we have various modalities like mammography. We have got breast sonography. Even breast scan was there. I very well remember that was the machine where it radiates some light and we can see whether it is malignant or no. We have got so many studies and so many eras of laboratory tests we can do. So definitely we have to undertake those. And today's two lectures are very good. Everybody must listen to them. And there is a lot of disturbance at the backside. Okay. I welcome Dr. Charulata Bapai, who is very dear friend of mine, and the other speaker and our chairpersons, Dr. Rohit Kumar also. So I am very much eager to listen to these two people today. So thank you very much for inviting me, and hearty congratulations for both of them, both the chairpersons, as well as we have been associated with breast committee since Neha Bhuyar was there. So I welcome again to Karnataka Dr. Charu Bapai. In spite of her busy schedule, she has joined. So thank you very much, Dr. Charu and Dr. Rohit both. Thank you very much.
Thank you.
Thank you, madam. Thank you so much for encouraging us. Any message, Dr. Lalita from Hiremat, sir?
Sir is not joining. His flight is
Okay.
for next 2 hours. So
Okay.
anyway, we miss him.
We can go ahead.
And now,
One more thing,
can-
Dr. Lalita, I just wanted to point out here. I just wanted the feedback who are listening to our webinars. So can you, lastly, you can just upload the feedback form, really what they have learned like this. Okay. So
Yes, ma'am.
just I want those feedback forms for my study. Really the whether webinars are useful or they want a physical one.
Yes,
So
ma'am.
for this one. Okay. Thank you very much again. Okay.
Do that. Yeah, we'll surely do that, ma'am. Now I take a great pleasure in introducing our first speaker, Dr. Rohit Kumar, who is a senior consultant in surgical oncology at Aster Chain of Hospitals in Bangalore. He has done his studies from Bellary and Mysore Medical College, as we can see. After that, he has got his training and super specialization from Manipal Hospital, Bangalore, under Dr. Somshekhar, and he continues to work with Som sir from then on. He is not only a great and ambitious surgeon, meticulous surgeon, but is also a very good teacher and a motivator. I say this with pride because he is my teacher and I am still a student. I feel very happy to have him here because he always pushes me to do better and better. And even now I discuss my cases with him. So I'm very proud that he's my teacher because I know him very well, how good he is in his surgeries as well as in managing patients. And he has done his various fellowships, including MSKCC fellowship from New York, USA, and traveling fellowships. And he has also got so many awards, including the Best Fellowship Despite his busy shift schedule in the OTs, he still goes for camps at the basic level. And I have gone with him for one such camp, for the breast screening camp. And that's why I thought he's the best person to be called for the screening, to learn from him for the screening for breast cancer. And that is why I was thinking he's the best person to enlighten us, because he also knows, he has trained so many gynecologists in fellowships in gynec cancers. So he knows how much a gynecologist know about the breast malignancy and gynec malignancy, and how much they need to learn more about the breast and the gynec malignancy. So he's the best person I could think of for this particular talk, who can educate us regarding screening of the breast cancer, as well as and tell us what exactly we need to know, how much we need to know before we think of referring a patient for management to the surgical oncologist. Over to you, sir. Rohit, sir. Over to Rohit, sir.
Is my screen visible?
Yes, sir. Yes, sir. I can see your screen.
Okay. Am I audible?
Yes, sir. You're audible.
Okay. Good evening, all. At the outset, thank you, Dr. Shipra, for warm introduction. And a heartfelt thanks to Karnataka State Obstetrics and Gynec Association, especially the Gynec Onco Committee and Breast Committee, for this opportunity to share my views. This is more about my passion to go for camps, as Dr. Shipra mentioned, to teach and to learn as well. So I'll be just briefing through or going through the perspectives of a gynecologist in breast cancer. Although I might not be an ideal person to tell the perspective of a gynecologist, but I would try my best to see what justice I could do to this. So I bring warm greetings from Aster International Institute of Oncology, which is a complete cancer care center where I work, and our main concern is to treat patients well. I also bring greetings from Association of Breast Surgeons of India. I am the secretary of the Association of Breast Surgeons of India. This is the association which stands as a voice for breast surgery in India and to improve breast cancer care as well. So wherever I start my talk, I always use Simon Sinek as the introductory slide as well. This is a YouTube talk which I would request everybody to go through once. The concept of golden circle. The idea is, if we know why we are doing, then we actually know the how and what just follows when we know the why that we are doing. So always start with the why. So let's look at our why today. Our why for today is to see and prevent breast diseases, mainly breast cancer. How are we doing it? We are going to doing it by empowering with education and examination. Two main E's for us, education and examination. And what are we looking at? That is the results, that is improved health and women wellness. And this is what I found when I clicked on Karnataka State Obstetrics and Gynaecology Association as well, that your main motto is educate, excel, and empower. I would add one more E to that, that is examination. So we are educating, empowering with education and examination. That is the main key for us for wellness of women. So our main objectives will be to look into breast healthcare in India. How is breast healthcare shaping up in India? Evaluation of a breast lump, triple assessment. Mainly, I would look into how clinical examination and mammogram can be looked at. Breast cancer in India, the changing landscape. I would also concentrate on breast cancer screening, that is breast awareness, I would call, rather than breast self-examination, and also a few things about mammogram. And finally, breast cancer prevention, what I would always look at, that is a 4-pillar plan, which I usually talk about wherever I go, which is more important to me than any other topics that I talk wherever I go. So breast healthcare in India, if we look at breast healthcare in India, breast surgery, it is just a budding or a growing as subspecialty. Dedicated breast specialists are very few, and they are slightly increasing in numbers. The concept of breast cancer centers or breast centers are just coming up to existence in all over India. We can find here and view centers where exclusive dedicated breast work is being done. Importance of early detection is very little, and it is gradually picking up in most of the places. When we look at, breast diseases in India, what is the usual phenomenon? First, a woman anxiously finds a breast lump. That is the first thing. Then the first person she reports is always usually a gynecologist or a general physician. What happens next? They're usually examined or may not be, and then they're referred for examination. And then after that, they are followed up with some inconclusive evidences or inconclusive findings. Then patient has to return back for the report. There is huge variation in the breast imaging reporting, and finally there could be either it is answered at that level or being referred to a surgeon. There are many important things which are not exactly a more common practice, that is triple assessment, which I'll be talking about. FNAC, which Dr. Charulata will be talking about, why core biopsy is the standard and not FNAC in breast cancer, in breast evaluation. And then frozen section, that we will just leave it off. We'll not go into that. So how do we approach a breast lump? Whenever a breast lump or a female with a breast lump comes to your OPD, how do we look at it? So the first thing, what will you diagnose as? So when we look at what is the risk of a breast cancer in the most commonest symptoms, a female patient usually comes with palpable breast lump. She will have a 10% risk of harboring cancer. Nipple discharge less than 0.5. If somebody comes with mastalgia to my OPD, I'm at ease. I'm already happy that at least part of it is not a breast cancer, a diagnosis. So the differential diagnosis when somebody comes with a breast lumps are, usually it will be a cyst, either a simpler cyst or a complex cyst. Next, it will be a fibroadenoma. Then we have series of fibroadenosis, benign breast lesions, fat necrosis, granulomatous mastitis, which is the most troublesome diagnosis that I can have or I can discuss with for patients that we are seeing very commonly these days, and then cancer. So all the diagnosis, any breast lump evaluation is very simply done with what we call triple assessment, which most of you surely know. What does triple assessment include? One, clinical examination. Next, after you examine, then you evaluate or confirm your findings with screening or imaging. And then if there are any suspicious findings or any untoward findings, then you confirm those findings with a core biopsy. So the three things are clinical examination, then we have imaging, and then we have histopathology. So what is triple assessment? As I told you, it's an evaluation of a breast symptom with clinical examination, imaging, and then histopathology. It includes all these things. So to start off with, whenever a female comes with a breast lump, it's usually painless most of the time. And then we ask about the relevant menstrual history, family history, feeding history, family history, and in detail, we have to examine the history as well. If at all the breast lump was, was it very commonly occurring every month along with the periods or not, associated with pain or not, was there any changes and all those things. Then we look at examination. So what does significant family history mean when somebody comes with a complaint? It means one or more close relatives, which is less than 40 years of breast cancer diagnosis, or close relatives who had breast cancer and ovarian cancer, or a male relative who's had breast cancer. Most women do not have a significant family history, and so their overall breast cancer risk is not affected. These are the various symptoms with which a female can present in the OPD. It could be either a thickened mass, indentation, skin erosions, discharge from the nipple, PD orange changes, changes on the skin, the inversion of the nipple, and all these findings. So gold standard for breast lump evaluation is triple assessment. This is how we find the various sizes of lump that can be diagnosed. We will keep this under our mind just to share, and then I'll talk about the importance of this later on. Now, this is the scenario which I commonly see. If I ask a question to any one of you, can any one of you tell which one of them is with cancer and which one of them is post-biopsy? It is difficult to comment, right? Imagine the plight of a surgeon or an oncosurgeon or anybody who's dealing with breast when they are doing. So the first thing, the main request for all the people who are seeing a woman coming with breast lump to you is first and foremost, as I told, the above two are because of the biopsy and ecchymosis. The below two are breast cancer with skin involvement. So what do we want? What I want, or what a surgeon looks at, or somebody who's managing breast cancer, is document the clinical finding before you send a female who has come to you with breast lump for biopsy or imaging. Anybody who comes to you with breast lump, this is the first thing on your OPD sheet. Just document, is the skin involved or not? How does it change? If somebody comes to me with a biopsy scar after the biopsy, then an early lesion, that is, if there's a 2 centimeter, less than 5 centimeter lesion, that is early, with the biopsy, any skin changes, it makes it locally advanced. So a female who is a early breast cancer, if she was, because of biopsy, by the time she reaches me, I overestimate it as to be a locally advanced breast cancer. You see the impact that it has, the amount of trauma that the patient undergoes, the entire orientation of a surgeon or an oncologist completely changes. So the first thing, my main request to all of you who are dealing, or any woman who comes to you, always first document the OPD findings on your file, if skin is involved or not, if nipple inversion is there or not, are there any skin changes, and then you do the further things, that is imaging or biopsy, whatever things. If you feel suspicious at any point, even at initial thing, please take the images with the permission and share them with your surgeons to whom you are referring. This clears the ambiguity for most of all. This is the first request for most of the patients or most of doctors who are dealing with the breast lump evaluation. Now I will discuss directly about mammogram, as Shukra had mentioned to me to discuss more about mammogram. So normally for an evaluation of a breast lump, whenever it is done, mammogram in a screening, it's usually done in two views, that is the craniocaudal view and mediolateral oblique view. You can see in craniocaudal view, the breast is compressed from head to toe. This is from front to back. So if I see the same thing here, this will be the front, this will be the back, this will be the medial end, this will be the lateral end. This is how it goes, and you can see the picture being demonstrated same from front to back. Okay, this is the craniocaudal view, and then next will come the mediolateral oblique view. You can see the compression happening here, mediolateral oblique view from front to back. So if you draw a line from nipple and above, from here it will be above, that is upper quadrant, and the below is the lower quadrant. This will be the pectoralis major muscle that is seen here. These are the two commonest screens that will be taken, that is craniocaudal and mediolateral oblique. So in a normal breast anatomy, you can see it is properly the skin fold on the outer one. You can see the nipple. You can see the medial fold here, and you can see the pectoralis major in the middle third. This has to be very much clearly seen. For an ideal reporting of a mammogram, you can see it should be always put up like this, back to back, right and left, craniocaudal view and mediolateral oblique view. They have to be mounted back to back, and they have to be examined like this. So let us look at most commonest things. So the very important thing for you is start from outside and then go inside. That is, you look at the skin, compare the skin of the right and the left, and then come to the nipple, and then look at the tissue and then go back as well. Same with here, mediolateral oblique. This is the axilla. You can see the axillary lymph nodes here, pectoralis major muscle. This is a standard and very well taken mammogram. This is a very well taken mammogram. Hello? Yeah, so a very well taken mammogram should be labeled and properly identified with quadrants. As I told you, for a left, this is the lateral view, this is the medial. For right side, this is medial and this is lateral. And same with quadrants, up and below, upper quadrant, lower quadrant. Very important to see in a mammogram is what is the density of the breast. This is the four most commonest patterns that we have to remember. This is a fatty breast. So breast will always have glandular tissue and fibrous tissue, and then it will have the fatty tissue. So our breast with most of the fatty is called fatty tissue. The density is because of the glands and fibrous tissue. So the more denser the mammogram, the lesser is the sensitivity of the mammogram to pick up any lesions. So anybody who has got a heterogeneously dense or extremely dense mammogram, please evaluate them further with ultrasound or MRI. This has to be done. Anybody who's got fatty breast and scattered, we can see the findings very obviously. But for dense breast, heterogeneously dense and extremely dense breast, they have to be complemented with ultrasound. Sonomammogram is not superior to mammogram, or mammogram is not superior to sonomammogram. They have to be complementary always. This is what same thing I told you. As and when age happens, usually the postmenopausal woman will have more of this thing. And usually in 50s, we will have heterogeneously dense breast. In 40 to 50, you will have scattered. Or postmenopausal will be usually fatty breast. So if you look at few patterns, this is the most common pattern. That is the dense breast. You can see there is a lesion in the right breast. It is retroareolar, or you can tell it is in the medial quadrant. This is medial quadrant. You can see here. There are few enlarged lymph nodes as well in this. It needs ultrasound for evaluation. So this is got a dense breast. That is why we are going ahead with ultrasound for furthermore evaluation. Next, we have a pattern 2, that is a fatty breast. This is a normal breast mammogram. You can see the lower fold. You can see the skin properly mentioned. You can see the middle part of the pectoralis major. Very well seen axillary fold and pectoralis major here also. And then you have extremely dense breast. You can see there is extremely dense breast. This patient has to be evaluated with ultrasound. So ultrasound and mammogram have to be complementary to each other. For younger women, usually most of the younger women will always have a dense breast. That is why mammogram is always recommended after 40 years. Anybody for evaluation of the breast less than 40, always begin with ultrasound first, because that has got more sensitivity. Because the density of the breast, the lesions will also appear as white. If there's any carcinoma lesions, any abnormal lesions will be dense white like this. And because of the density, the mammogram will not be able to pick it up. So ultrasound for less than 40, for more than 40, then mammogram you can lose accordingly. So you can see sensitivity of mammogram 85 to 90% in a fatty replaced breast, whereas in a dense breast it is only 60%. That is why you have to choose your investigation when you're doing or evaluating the breast. Primary signs of cancer on mammography will be usually a mass or a calcification. You can also see all these things. I will not discuss about all these things. All you need to remember is to look at changes. That's all. Now, the maximum limit of mammogram is usually 0.1 to 0.2 rads. It is very safe. It is not at all. Radiation exposure is very high. So the usual way of reporting is in the form of BIRADS 0, 1, 2, 3, and 4. Anybody with a 0, always remember, please remember, BIRADS 0 means they have to have further evaluation. That means the evaluation is incomplete or not satisfactory. 0 means doesn't rule out that it is normal. 0 has to be evaluated further. Next comes BIRADS 1, which is negative, can be followed up once in a year. Then you have benign, that is BIRADS 2, that also can be followed up. If there is anything in BIRADS 3, then it is probably benign or a doubtful lesion. This patient has to be followed up with 6-monthly or early monthly follow-up. BIRADS 4, 5, and 6 are more towards cancerous lesions. So remember, BIRADS 0 doesn't mean that patient has to stop. You have to evaluate them more than everybody else. BIRADS 0. BIRADS 1 and 2, you can follow it up with routine mammograms. BIRADS 3 needs further evaluation for within 6 months early follow-up. And then, or else you can ask for ultrasound or MRI in these patients. So when do you do breast ultrasound? Breast ultrasound is important in a dense breast. It's a very important tool in a dense breast. You can see most of the time now, as you all people do ultrasound, you are very well aware. You are more better in doing ultrasound actually. In fact, you also can do and start doing on your own. You should look at echogenicity, margin shapes. We'll not look into depth of it. We'll look at the indications for breast ultrasound. That is, anybody with a breast lump less than 40 years of age, anybody with a breast lump during pregnancy or lactation, if the mammogram is abnormal and not able to conclusively tell you, or anybody with a breast mass with a negative mammogram. Ultrasound is also needed in terms of mastitis or evaluation of nipple discharge when there will be dilated lactiferous ducts. Also in terms of breast implants. Ultrasound is very much needed for biopsy. Remember, nipple discharge, if there is a blood-stained nipple discharge, then the chances of malignancy is very less. When there is a serous watery discharge, painless, spontaneous serous watery discharge, the chances of malignancy in that nipple discharge is very high than with a blood-stained nipple discharge. Please remember this. So this is about the ultrasound frequency. It's not so. In general, less than 20 years, always ultrasound. 20 to 30 years, first ultrasound. If needed, mammogram. So in general, anybody less than 40, always begin or start with ultrasound and then further move ahead. For anybody above 40 years, you can do mammogram first. If it is inconclusive, then come back to ultrasound. Remember, ultrasound is a subjective phenomenon. It depends entirely on the skill of the radiologist who is doing. Whereas mammogram is an objective phenomenon. It depends on whoever is seeing and interpreting it. That is why mammogram is very important and ultrasound can be complemented. Now, when do we do MRI for evaluation? The usual guidelines for MRI is for patients who have breast cancer gene mutation, that is most commonly BRCA mutation, or anybody with a first degree relative of breast cancer or a carrier, and anybody who has got a lifetime breast cancer risk of more than 25%. These people need to be evaluated with MRI of the breast starting as early as the age of 25 sometimes, or at least 5 to 10 years earlier than the diagnosis of the primary caregiver or the first primary relative. These are the non-screening indications for breast MRI. We'll not look into it. Now, to assemble or to complete off in a well, this is of triple assessment, that is clinical examination. I will be talking in detail about how to do clinical breast examination and a self-breast examination, how you can teach your patients to do those things. And then radiological examination, where you have sonomammo, mammogram and MRI, and pathological examination, FNAC, core biopsy, which Dr. Sarwat will be talking about. So remember, triple assessment is the gold standard for breast lump evaluation. Now, since we are talking about breast cancer, October is the breast cancer awareness month, we will look into a few aspects of changing landscapes in breast cancer. Knowing is always not enough. We have to be informed and we have to be knowledgeable. So all over the world, you can see breast cancer is the most commonest cancer, followed by lung cancer in both the sexes as well as in females. Now, if you see in the world, nearly most of the countries, that is in 160 countries, breast cancer is the #1 cancer for diagnosis. So it is the second most common non-communicable disease globally after cardiovascular disease. That is in general cancer I'm talking about. In India, in 2008, cervix was the most commonest cancer. It was replaced by breast in 2012. And then since 2012, breast cancer is the most commonest cancer in women and compared to both the sexes as well. You can see even in 2018, nearly 1.6 lakhs. Actually, this number is underrated. In fact, we have at least 3 to 4 times the number of this. But the more important thing about breast cancer in India is not about the diagnosis. It is about the deaths. For every 2 women who are diagnosed with breast cancer, 1 woman dies of it. Imagine, that is more than 50%. If 1.6 lakh patients are diagnosed with breast cancer, 87,000 are dead. What we were talking about, the highest mortality, we were talking so much about coronavirus and COVID infections. What was the mortality rate of COVID in India? If you take maximum, it is 5%. And what we're looking at in breast cancer, it is 50%. That is why we are talking so much about breast cancer. Now, the worrying trends in India are most of the women have got grade 3 cancers. Most of them, now we are seeing an improvement. In last 2 to 3 years, the average lump size has been decreasing. There has been increasing awareness about breast cancer screening. The overall survival, 5-year survival rate has been around 60%. You can see in India, we are seeing there is a change in the age shift. You can see when compared to the Western literature, our Indian setup, we are seeing breast cancer in 40 to 50, a 10 decade earlier, and we are seeing more of triple negative cancers as well. That is why we are more, need to be more aggressive and we need to detect them as early as possible. Now, if you look at the unfavorable statistics when compared to India and US, the average age of diagnosis, you can see it is nearly 10 decades less. And the percentage of cases detected are usually late. Whereas compared to US, it is around 10%, it is 60%. Most of them are detected in stage 3. And the survival rate, you can see, it is very bad. The annual incidence rate is climbing, whereas in US, it is plateaued. Percentage of women screened, the screening is very much less in India. That is why we need to promote breast cancer, breast awareness. And then radiologist, as we all know, is very much less. So the primary contact are most often you people. So you are the ones who can change the breast cancer scenario. Just as you people are changing the cervical cancer scenario in India, the changing of the breast cancer diagnosis or the numbers entirely depends on how good a gynecologist or our gynecologists are going to do. You are the ones who can change women's life. Now, why are we talking so much about early stage? Stage 1, the 5-year survival is 98%. Stage 3, the 5-year survival is fallen down to 40%, from 98 to 40%. So, earlier the diagnosis, the lesser the treatment, better the outcomes. You can see in early stage cancers, stage 1, almost 98 to 99%. In stage 4, it is less than 20%. This is how I teach or I explain to most of the friends when I go to screening protocols or camps. You see this curve here. If they're diagnosed very early in stage 1, what it costs to them is just the cost of laptop. As and when the stage increases, you start losing your car, your holidays, your house, everything. And what is it worth? In spite of spending so much, in stage 4, your survival is almost nil. Whereas in stage 1, your survival is highest. So we need to detect as early as possible. How is it possible? By screening test. What are the screening tests available for breast cancer or for evaluation of a breast lump? We have 3 modalities. One is breast self-examination, then examination by a physician, and then mammography. Breast self-examination usually starts off in the age of 20 years itself. Clinical breast examination can be started off from the age 20 every 3 years. Mammography, what we're usually telling is to start off at the age of 40, at least once in 2 years, and then as per the risk, shift over to annually. So breast self-examination has been found to decrease the mortality by at least 18.8%, even the clinical breast examination as well. So let us talk about breast self-examination. So when should a lady do a breast self-examination? First, when? The time. The time is ideally 3 to 4 days after the period ends. That is usually around 10th to 12th day. That is the time when they will not have much breast congestion. They can examine their breast very well. For an elderly woman, for somebody who's had menopause, they have to fix a date. So when to do? Young ladies, whoever is menstruating 3 to 4 days after your period ends. For somebody who is postmenopausal, a day should be fixed in a month. So now, how to do it? The technique is most important. This is what you teach to your patients when they come to meet you. You always have to see the most sensitive area is your pulp. This is how we do the clinical examination as well. The same way, pulp is very much important. The flexion is at the metacarpophalangeal joint here. And then you have to examine from your pulp and not from your pads of the fingers here. You have to examine from the pulp. Each area is examined with different pressures by a circular motion. So what do we talk about breast self-examination? What is it at all about? It is only about the commonest rule is you know what is normal for you. If you know what is normal for you, then what is abnormal can be easily found out. This is what it is made out. It is think about looking and feeling. You look for it and you feel for it. So what do you look at it? A woman is asked to stand in front of the mirror and she has to look for the changes on the breast, starting with nipple. Any nipple discharge, nipple inversion, nipple changes, then skin of the breast, then armpit, that is the axilla. They have to see, that is look for the changes. And then after you look, you stand in front of the mirror and see all these things. And then after that you feel. How do you feel? That is, you mark the boundaries. The clavicle above, below is the inframammary crease. Medially you have sternum and laterally you have axilla. So you go on from medial to lateral, up to down, slowly. Either you go in a circular motion inside outside, or you can go in a linear fashion like this. This is how you can do a proper self-breast examination. When do they have to consult a doctor? If there is a lump, if there is changes in the breast shape, any skin changes, any nipple discharge, then you have to communicate to your doctors. So clinical breast examination is done by us, that is performed by doctors. It has to be done annually for women over 40 years, at least every once in 3 years for women between 20 to 40, more frequently for high-risk patients. So what is important when you are doing a clinical breast examination for us as a clinicians is, what is the position of the patient? We need to know the breast boundaries, the pattern of examination, how your fingers should move, and the duration of the examination. That is, what is the minimum time required for a proper breast examination by a clinician? That is the minimum time. So a clinical breast examination requires flattening of the breast tissue against the patient's chest. So patient should be in a supine during the examination. The breast tissue extends laterally towards the axilla and superiorly towards the clavicle. You have to cover a rectangular area, as I told, bordered by the clavicle superiorly, inferiorly by the xiphisternum or the inframammary crease, medially by the sternum, laterally towards the mid-axillary line. Palpation either begins, as I told, from medial to lateral or from lateral to medial. As I told you, the examining finger has to be flexed at metacarpophalangeal joints, and the pulp of the fingers has to be used for examination and has to be palpated with light, then moderate pressure, then deeper pressure. So the minimum time that is required is at least 3 minutes. I don't think many of us will do 3 minutes, not even me myself. So as much as possible, the minimum time, at least 1 minute of time is needed to properly examine a breast. So discuss with the patient the time needed to do a complete examination and tell them about the procedure as well. So when used as a screening tool, clinical breast examination has proven to reduce the breast cancer mortality as well. So we've already spoken about mammogram. Now clinical breast examination and self-breast examination. Both I have talked about in detail. So when do you do mammograms as such? The usual recommendation is to start off the mammogram at 40 years. What is important is to understand that we have to assess the risk of the individual. Is it an average risk, moderate risk, or high risk? How do we assess the risk? We have various tools to assess the risk of a breast cancer. Online, we have Gale's model. It is just a model. You can just click, go, and enter the questions what they ask. Then you will know the risk of the female. Once you know the risk, anybody who has got a high risk needs to start off at least by the age of 40 or by the age of 35 itself. So ideally, in Indian setup, we tell to start off at least at the age of 40, and then initially at least do it every once in 2 years. The recommendation is always annually. What is most important to explain to the patients is the importance lies in mammogram to do in every subsequent years, and in the subsequent years you have to compare it with the previous mammograms. That is when we will be able to pick up the lesions very early. This is most important. We have to compare the mammograms with the previous year's mammogram, not only the present mammogram. That is why it is very important. So the usual to start off is at 40. It can go up to 75. Usually there is no upper age limit to end mammograms. You can go up as when then the life expectancy is there. And then to follow it up every year, that is what we usually follow. Anybody who's got a very high risk or a familial history of breast cancer needs to start to do a breast cancer screening at least 10 years before the age at which the first breast cancer was diagnosed in that family. So this is the difference what I told you. You can see an average size lump found by a woman getting regular mammograms. This is important, regular mammograms. if you do regular mammograms, you can pick up the lesion that is subcentimetric, less than 0.5 centimeter also you can pick up. As in when the mammograms are rarely done, you can see the lump sizes. The same is with the size. You can see a lump found by a woman practicing occasional breast self-examination. Occasionally, if they practice, the sensitivity is less. The more frequently they're practicing, at least every month, they'll be able to pick up very easily. So the most important thing is consistency. Now, mammogram has been found to be, the modality which has changed how the breast cancer has reduced the mortality. Now, the myths about mammograms, there is the radiation exposure, as I told you, is very less. It doesn't cause cancer or dissemination of the cancer. Now we have patient-controlled pressure for the mammograms, so the pain can be less. So if a mammogram is normal, there is no cancer. Please don't think this. And all abnormal mammograms need to be evaluated. So it is always and always, as taught by our teachers, the combination of clinical examination, history, examination, and then you go towards biopsy. It is in correlation with everything, not isolation. Just see mammogram until biopsy. Just see mammogram until not to do this. Not the thing to do. Now, discussing about some risk factors about breast cancer, which we need to know. The most important thing is obesity. As we all know, very well know how much common it is that's happening. We have discussed the obesity. So how does obesity leads to breast cancer or any cancer for that matter? Obesity is a state of subclinical or subacute inflammation. And also there is raised insulin levels. Raised insulin level, insulin-like growth factor, they are the growth factors which promote the development of most of the cancer cells. And also, obesity causes higher amount of estrogen, which is main cause that is responsible for developing breast cancers. I will discuss in brief about all the risk factors. I have a short thing to ask for all of you that I will certainly ask for. The most important thing that we underestimate in discussing with most of our patients, whenever anybody comes to my OPD, the first question I am asking them is, are you sleeping well? Are you eating well? Are you walking well? Or how good you feel about yourself when you wake up? What is the health level of yourself when you grade between 0 to 10? If you ask these 4 questions, you will get the answer by itself. What is problem with this patient? So the most commonest thing underlying at this age is usually either the stress, and then comes sleep, and then comes work pressure, and then food and habits. So the effects of chronic stress, we all know. Stress is very important for all of us. If we have to function well, the most important thing is stress. But what is wrong is chronic stress, not acute stress. So how does a chronic stress promote cancer? If you see, even in India, and this is one of the paper which I would ask for everybody to go through once. This was published in 2013. Higher status occupations and breast cancer, a life course stress approach. This paper is very much relevant to this year's, to this society of what we are going through. Women in professional and managerial occupations, they had an elevated breast cancer risk when compared to people who are at lower professions. 20% of the effect of professional occupations was explained by the estrogen pathway. Job authority was related to higher breast cancer risk, especially with longer duration of holding authoritarian positions. What I really don't know what to discuss when I talk about this. When I looked into a lot of literature, I asked a question about to myself, why is a breast important for a female? Is it it's very, I might find it might be a very debatable question. Was it for good or was it a curse? It is a very debatable question. It brings about a lot of questions. Let us keep that aside. Now, we all know we are seeing most of the young females attaining menarche very early and postponing marriages, postponing pregnancies, postponing lactation. All these things are adding up to the risk of higher levels of estrogen exposure for a woman during her period. And we very well know this is the main causal factor for increasing the risk. Along with that, addition to that comes this stress. Salutes to all the modern women who handle the family, who handle the job, who handle their personal life. I mean, as always said, it is impossible to do what a woman can do. And my salutes to all the women who are there. But this comes at a risk of your own health being put at risk. That is why please prioritize your health. Most importantly, your sleep and how you handle or what you eat. In fact, you have to be the first person who will eat in your home than the last person. And sleep well. That is most important. We will discuss this in things further. So this was a question that was asked to most of the breast cancer diagnosis women, that was there a diagnosis of stress in you when you were diagnosed? Nearly 60% of them told that the stress at work or at familial level was the most commonest triggering factor for them. In fact, in all my OPDs for most of the women less than 40 years, if they come to diagnosis, if I ask them, they will definitely put and tell me, yes, I have had either a diagnosis of polycystic ovarian disease, I have had thyroid disorders, I have had some skin changes, I have had stress, and I'm not eating well, I'm not sleeping well, and there is a lot of stress. This is the most commonest thing. I know all of you would have seen in your OPDs the same questions, same answers. So how does sleep and stress go? All these things are the same. I would stress upon most important thing is, handling of stress at one point. The other important thing is sleep. Why is sleep so much important? So in fact, if you look at only the cancer, if I talk, forgetting all other aspects, if somebody tells that why should we sleep? Anyways, when I'm going to die, I'll sleep well. Then I will tell you, if you're not going to sleep, you'll definitely die soon. Don't worry about it. Sleep is one such modality which Mother Nature has given to us. In spite of, what are we doing when we're sleeping? We are neither achieving something, neither we are reproducing, nor we are recreating, and we are at most risk or most vulnerable. In spite of all these things, Mother Nature has put sleep in our schedule. Why? Because that is one thing that heals everything of our life. Right from the time you open your eyes to close the eyes in the night, all the emotional trauma, physical trauma, mental stress, if everything has to be healed, processed, and then for you to go back fresh next day, the most important thing is sleep. Am I just talking or is there evidence? Yes. Natural killer cells. These are the ones that handle cancerous cells. If a single night of less than 4 hours of sleep will drive 70% of natural killer cells away from your circulation. In fact, WHO has recognized night shift as a carcinogen. Anybody who sleeps less than 6 hours is associated with a 40% increased risk of developing a cancer. So this is one of the rat model study that was conducted. When sleep deprived mice, they nearly had 200% increased risk of developing cancers. This is because of the alterations in M1 cells and M2 cells. This is also there in our body as well. That is the importance of sleep. It is not only for cancer. It is to bring out the best in you for your creativity, for your each and everything, for your emotional trauma, for everything. Your sleep is very important. So sleep deprivation causes increase in sympathetic nervous system, which leads to increase in unnecessary sustained inflammatory response. This is the main reason responsible for all the ill health that is happening in this generation. And cancer causes is usually because of inflammatory cells or inflammatory situation. And rest of the thing is about all sleep and all. Yeah, now moving into the 4-pillar plan, which I usually talk. Whenever you talk to your patients, if you want them to be with you, this is what I have found. This is all I discuss to all of my patients. You talk to them about food. You talk to them about their sleep. You talk to them about their movement and about their relaxation. This is what we can make them change their life. And this is what will make them stay with us. So moving into food, I will put up very simple, straightforward simples, which all of you already know, which is very easy to discuss with your patients. The only thing that we have to discuss, most important thing which all of us know, is denormalize sugar. The simple funda, if anybody asks me what to eat, what not to eat, anything processed, anything refined should go out. Anything as close as possible to the earth or easily available for that area should be the first priority. Our food should be most often with as minimum of 5 colors. With respect to fruits, there is a lot of abnormal communication. Always have fruits before evenings. Don't push your fruits after your evenings. Try to have fruits as early as possible. And we very well know about time restricted eating, which has brought about so much changes. In fact, I will put up a last slide, which is very much important. I would request all of you to go through that, and then I will put up that thing. And hydration as well. That is very much important. So movements, we know how much we talk about, 1,000 steps, 10,000 steps, 7,000 steps, all those things. Do we have any evidence for all those things? This was the one that was published in JAMA Oncology, that a minimum of 7,000 steps. If anybody walks less than 7,000 steps per day, they have 70% increased risk of mortality when compared to a person who's walking more than 7,000 steps. This is the minimum time. But what is more important is a short burst of activity. If you are just able to climb 1 stairs in your home, just run as much fast as possible and just relax. That is most important. That makes your body feel that you're alive. That is the most important thing in activity. So if anybody tells I don't have time for jogging or exercise, that is not at all important. What is most important? See, this is a slide which I want you to take home. The most important thing is active all throughout the day. Somebody who just walks early in the morning and sits entire day is not at all useful. You can see here the amount of sedentary. The more the sedentary you are, the higher the cancer risk, higher the disease risk for all the diseases. So the more active you are, take breaks in between as much as possible. Just climb 1 stair of flights. That is all you have to tell your patients. And then sleep time, I don't have to tell. The most important thing about sleep is to sleep. I cannot tell anything more than that. That is the importance of sleep. Anybody who's having coffee, always try to have your coffee before 3 o'clock. There is a lot of science behind it. I will not discuss for lack of time. Relaxation, I know most of you are already practicing about relaxation. More than anything at all, about beyond all the 4 pillars what I talk. This is what I would request all of us to develop and to speak to our patients. This is the longest study that has been done in the human history to find out who is most happiest. This study, if you just Google or if you put in YouTube, you'll find this study. This is Waldinger, who talks about this on YouTube as well. This was conducted for more than 72 years and it is still going on. The most common reason or the happiest person in this longest study was the one who has got a good, happy relationship, who can maintain a good, happy relationship in their life. That is all we are. In fact, if you look at, as individuals, we are nobody. Together, we are always together. So if you have to relate to yourself, we are human beings. So we have to relate to somebody. So try to develop good relationships. That is all that takes for us. So, and the other thing what you can always talk to your patient is about sick care and health care, which I always talk, which all of you know. When you're healthy, concentrate on your health. Don't think of your health just when you're sick. If we are happy and taking care of our body very well when you're healthy, then we can be healthy when you're sick as well. So to find up, in terms of breast awareness, what is important is tell your patients to know what is normal for them. How do they know? The only thing, breast awareness, self-breast examination. If they know what is normal, then you should know what changes to look and feel for. Look and feel. Look at the changes, feel for the changes. If there are any changes, please report to your doctor. That is all you have to tell all the women. And my OPDs are never ended up without telling for all the women about cervical cancer awareness and breast. And I've already told assessment about for clinicians, a good history and clinical examination is always told. Self-breast examination, clinical breast examination, as I told, pulp of your fingers, flex metacarpophalangeal joint, spend minimum at least 1 to 1.5 minutes. And then mammogram, anybody less than 40, always use ultrasound first. After 40 years, mammogram first, and complement with ultrasound if needed. What you have to remember is the density of the breast. If mammogram shows a dense breast, then your mammogram is not sufficient to evaluate that patient, whatever be the age. You have to add a complementary ultrasound to that patient. Very important, core biopsy, which Dr. Saralata will be talking about to follow. APSI, as I told, Association of Breast Surgeons of India, we look for, main thing is prevention and early detection. That is what we ultimately aim for. And this is what I want to discuss. The most important thing, the most important slide. This is just a video I'm putting up. This is Dr. Mandy Pels. There is a YouTube discussion about her. This is the talk which she has given. The channel is The Diary of a CEO. I don't have any attachments for any one of them. This is only out of interest. I'll tell you the exact time also. Time it at 1 hour of that talk. From that 1 hour, you listen for the next 20 minutes. You ask your patients and yourself, most of the women and the counterparts, that is our males, to listen to that part. How she explains why we are having so much disturbances in cycles and so much increased disease. The progesterone phase, estrogen phase, and corticosteroid relation in that phase. How a woman should be addressed, how you should take care of your health at that time. That video, this exactly at 1 hour you start and up to 1 hour 20 minutes. Just spend 20 minutes and listen to this talk. If you're interested, please listen to that entire talk, which will change the way how you will look at yourself and how you will treat your patients as well. And then, as I always tell, best medicine for us is always PR, and we must always become the change that we want to see. Thank you. If there are any questions, I'm happy to take.
Very nice, sir. Knowing is not enough. Informing is important in breast diseases, in preventing breast cancer especially. We shall definitely take home this message. I request now Dr. Rajeshri Palladi to give concluding remarks.
At the outset, well, it was a spellbound kind of state when we were listening to Dr. Rohit Kumar of the talk on gynecologist perspective of preventing the breast cancer. We keep hearing so many things on and off for the past 3-4 decades, but I think what has been pointed out so very well in the recent is the stress, the amount of stress, the lack of sleep, the obesity, and very surprisingly, the kind of challenges that the women go through thinking they are successful, but at the cost of what? I heartily appreciate for your extensive talk of the topic and very well selected by the committee chairpersons. I'm very proud that Dr. Lalita and
Thank you, ma'am.
Yeah, are doing an extensive, fantastic job, Dr. Shipra. Two things which I would like to mention here is that a simple way of making the woman aware that she has to go for self-breast examination or check on whether the women are aware of their breast is to talk to the attender who is coming with the pregnant patient. It could be either her sister or an in-law or a relative or a mother or etc. Take a time off. And I think that is the point when we can sensitize them the best, because they have actually come as a companion with somebody, but then you talk about them, then they feel pampered and cared for. So this one thing which we do practice in our outpatient is that just turn around and talk to the attender who is there along with the patient. You will have 1+1 offer. You have already your obstetric patient and then you have your gynec patient chipped in. And another important is the rise in the incidence of breast cancer in the men. So having a history of breast cancer in the men is also very important. And sir, would you like to ask for any history of cancer in the relatives of the BRCA genes, and should we sensitize the patients that if there is a history of any such disease in the family members and the BRCA genes, and along with the ovarian tumors, which we all very well know that, and also the prophylactic mastectomy now, which has become a fashion statement for most of the, elite, that as you rightly pointed out at one point, now, is it a blessing to have a breast or not, which makes us all think that after serving a purpose, do we really need to carry it? Because so much is the rise in incidence of breast cancer. I heartily congratulate you for all the topics which you have touched upon, right from the BIRAT score, right from the breast examination, right from the way in which we should approach to the patient whenever there is a lump. And especially so, the slide was very catchy when you depicted what would be the financial burden for the patient's family when it is detected in the later stage, which we have seen very closely in good number of families and friends, which has happened. I must say that breast cancer is very close to my heart. Last year, I lost two of my very good friends, the schoolmates, to breast cancer. And one was in England, who was staying in the best of the facilities. But, once it is detected and there is a metastasis, then we lose the game. And yeah, it's a lost battle, irrespective of how best we are going to give and offer our treatment and care to the patient. It becomes so pathetic that in the last stage, her family was expecting me to go and see her, but I was feeling so devastated and helpless that I really couldn't gear up myself to, go and address the family. Such is a scenario that we come across, and too many things happening, and COVID has taught us that back to basics is the norm of life, but still we fail to compile with that. And maybe the basics which were there back then were quite protective for the woman in terms of, her health, her mental health, her physical health, her well-being, etc. It's time, maybe in the coming 4 or 5 decades or 2 to 3 decades, that again, it becomes that we need to balance out our life, because at the end, what is it that we are reaching out to, and what is the rat race for? Everything becomes a philosophical part of, the journey, and medicine that we practice. Maybe after 3 or 4 decades of our practice, we come to realize that there is something more beyond which we need to do for the patients. And yes, this is one very important aspect which we can really do for the patients, and making them aware of what breast cancer is going to be, and what is the impact, and how simple things like sleeping well, eating well, and feeling well are going to go in a long run. Not only I feel about the breast, and also for the relationships, because as we mentioned, that relationships are very important. And I'm quite aware of the study which you had mentioned, sir, going on for past 72 years or 75 years. And that is a wonderful concept. And I think the world will sit upright and notice this study, that it's very important to value and nurture the aspects that were mentioned in your presentation. Hearty congratulations to you, to Dr. Lalita and Dr. Shipra. Thank you so much.
Thank you, ma'am. Thank you, ma'am. Thank you for your very positive inputs and overall feedback. And questions can be answered if it is in the chat box, and we'll take it up at the end of both the sessions.
Yes, we could do that.
Thank you, sir.
And again, congratulations for a very, very, insightful talk, very thoughtful talk, actually, because it makes us sit upright and notice that apart from the physical examination, investigations, evaluation, treatment, what is it that we really need to think of? Thank you.
Yes. Thank you, sir, once again. I now invite Dr. Charulata Bapai to speak, where we are eagerly waiting. And her topic is Gynaecologist's Perspective in Preventing Breast Disease, with special reference to needle biopsy for gynecologists. And it's my pleasure and honor to introduce her. She is Director of GEMS Hospital and also consultant at Dinanath Mangeshkar Hospital and Cloud9 Hospital at Pune. She is chairperson of FOGSI Breast Committee and also clinical secretary of POGS this year. And Madam also has spoken nationally, internationally, and has won many awards nationally and internationally. Our pleasure to listen to you today, ma'am. Please go ahead, Dr. Charulata Bapai.
Thank you so much for those kind words of introduction. Am I audible?
Yes, ma'am.
All right. And indeed, it is a pleasure to be a part of this Kasogai event. And thank you very much, Dr. Lalita, Dr. Rajashri Paladi, Vidya Thobi ma'am, for this opportunity. After that exclusive talk by Dr. Rohit, I mean, I could call it an oration. I think, most of the points have been clarified to a large extent. And so my job has been made very simple. Is my screen visible?
Yes, ma'am. Yes, ma'am. The screen is visible.
All right.
Your CV is visible, ma'am.
Yes, that's right. I will. So after that exclusive talk by Dr. Rohit, I think that I will be just speaking a little bit about the core needle biopsy or the techniques of biopsy. Well, actually, I may not be the right authority to do so, but it is just that we, as the breast committee, have come forth for the first time in the history of Foxy with the core needle biopsy workshops. I think Lalita and Dr. Bhatt have been fortunate to be a part of the BreastCon 2023, wherein we had our first ever core needle biopsy workshop for gynecologists. Well, the point is that knowledge is free for everybody. All of us are using our ultrasound machines for follicle monitoring, for, some are even into fetal medicine, some are doing it only for basic scans, but we all have that small probe, which is for the small parts. And that is the time we realize that we too can do a breast ultrasound. We too should be familiar with how the breast looks on ultrasound. We too could possibly drain a cyst, which is troubling our patients. And of course, we can also do a core needle biopsy for this using these devices. So I think most of the points have been covered so fantastically by Dr. Rohit that I will not be speaking on all that has already been said. Just one or two points which I would like to re-highlight is that in India, the basic difference in the Indian scenario is that the average age of the high-risk group is younger in India, which is 43 to 46 years as compared to the West, where it is 53 to 57 years. And so, some of these women may even be in the childbearing age group when they come to you. And so, as Dr. Rohit rightly said, we must make it a habit to examine the breast of each and every woman who comes to us for whatever symptom that she may have come for. As has been rightly said, that in India, most cases are diagnosed at stage 2B and beyond, as compared to the West, where they're detected much, much earlier, because of which the 5-year survival in the West is so much better than the 5-year survival in India. And this is what we as gynecologists hope to try to change by helping with early diagnosis of breast cancer. Teach your brain and train your hands. As Dr. Rohit has already said, that we have to make our patients breast aware. Okay, we have to teach them the commonest symptoms of breast cancer. And in a country like India, where even talking about the breast is taboo, touching them is an even bigger taboo. And this is what we have to try to, change in our country, make them be able to feel their breasts, and they have to understand how to examine their breasts. This has already been discussed in great detail. I'm sorry, but what does evidence say? Well, at present, there is insufficient evidence that breast self-examination is effective in reducing mortality from breast cancer. Breast self-examination is of interest for the early detection of breast cancer, especially in areas where mammography and regular physical examination of the breasts are not practicable as public health policies, which is exactly the case in our country. And so in our country, self-breast examination is indeed mandatory. Love your breasts, touch, look, and check. Become breast aware is what we say. As has already been discussed about the triple assessment algorithm, the clinical assessment, the imaging has already been talked about. And so I'm just going to touch upon the techniques of biopsy. So our take on self-breast examination is that the breast is a very easily accessible organ, making it easy to get self-examined. It is one of the most reasonable and feasible approaches to early diagnosis of breast cancer, especially in developing nations. Of course, there are a number of barriers to self-breast examination, like, women can say that they don't have the time, there is shortage of self-confidence, fear of possible detection of a mass, and feeling of awkwardness about breast handling. Many others like health-related assumptions, anxiety and forgetfulness, low socioeconomic status, a lot of negative socio-cultural perception about the breast cancer, and strong belief in traditional medicine, and sometimes lack of motivational support from parents, spouse, or friends could also be a barrier to self-breast examination. Most of this has been already talked about. The detailed history has been talked about. Clinical breast examination is done. And we have this fantastic study by none other than Dr. Rajendra Badwe, who's the head of the department of Tata Institute of the Tata Cancer Institute, that definitely clinical breast examination is going to help to reduce the mortality because of breast cancer, because of early diagnosis. So yes, we do play a very important part in helping to in early diagnosis. All this has been discussed in great detail. Again, just a revision wherein we say that between the age of 40 and 44 years, there's an option to begin annual screening. But just as we just discussed, that in India, we are having breast cancers at a younger age. And so let us not keep it as an option. Let us make it a compulsory habit. Between age 45 and 54 is annual screening, and age 55 years and above, screening every 2 yearly, but there's an option to screen annually also exists, and discontinue screening when life expectancy is less than 10 years. These are the current guidelines. We had a very good talk about ultrasound, and Dr. Rohit, clearly mentioned that in the younger age group and for women with dense breasts, for pregnant and lactating mothers, ultrasound is the best tool. But when we talk about screening, that time it means that there is no other problem which is present in that woman, which is clinically palpable. So it has been seen that ultrasound screening in asymptomatic women causes an unacceptable false positive and false negative outcome, and hence it is not acceptable for breast cancer screening. So whenever we talk about screening for breast cancer, which starts after the age of 40, it has to be mammography. If you can feel something, if you can feel a fibroadenoma, if you can feel a cystic structure, if you can feel some abnormality, then in the younger age group, it is always the ultrasound first. And if you feel that, it is not adherent to all the benign features on ultrasound, then yes, even if she's a young girl, say 20, 25-year-old, we are definitely going to subject her to a mammography. I had a young girl as young as 28 years of age, where she had a very, very high, strong family history of CA colon, CA pancreas. Her grandfather had some kind of lymphoma, and she came with a very tiny lump, which was barely 1 centimeter. But she had such a strong family history. Immediately on ultrasound, it looked like a fibroadenoma. But because of the strong family history, we subjected her to a mammography, a biopsy, which was mammography guided. And unfortunately, it turned out to be malignant. So in younger girls also, we will have to do mammography sometimes. And in older women, along with mammography, ultrasound is almost always combined. But as a screening tool, it is always better to use mammography as compared to any other technology. Most of you must have heard of thermography. Many people come and say that, doctor, thermography is an upcoming area, and it uses infrared camera to detect heat emissions. Now, malignant cells need oxygen-rich blood for growth, causing an increase in the temperature. No radiation, no pain, breast size, density is not a deterrent. It is a very cost-effective method. So in thermography, they detect hot areas. So for this, what they do, they cool the breast first, and then they have a non-touch technique by which they identify the hot areas. But if the patient has fever, there are some other causes because of which, she has mastitis, she has an abscess, these can be wrongly diagnosed as malignant areas. And so most of the breast surgeons, which probably even Dr. Rohit will definitely acclaim, that they do not advocate thermography as a screening tool at all. Instead, they always stick to mammography. MRI has been discussed about. And yes, once again, just a small guideline for screening for breast cancer. Age 20 and above, self-breast examination monthly. Let us remove the optional word. Breast clinical examination once every 3 years. Age 40 and above is mammography, which is done annually. And in high-risk patients, a mammography plus an MRI will be done annually starting from the age of 30. Well, this is just to touch upon the BRCA gene. We know that genetic counseling is also a part of screening for breast cancer. What we have to remember is that the BRCA gene is a human tumor suppressor gene. It is a caretaker gene. Its protein is responsible for repairing DNA or destroying cells if the DNA cannot be repaired. And so the BRCA gene is a cancer fighter. A mutated BRCA gene, if it is present, then the body is less likely to be able to repair the DNA, which can lead to uncontrolled multiplication of the cells, causing cancer of the breast, ovary, and maybe the colon. So just a BRCA gene mutation per se is not going to cause cancer. The patient is just going to become higher risk for cancer. So what is the risk for BRCA mutation positive women? Women with an abnormal BRCA1 or BRCA2 gene have an 80% risk of developing breast cancer by age 90, a 55% possibility of developing ovarian cancer with the BRCA1 mutation, and a 25% possibility of ovarian cancer in BRCA2 mutation. But friends, here we can see that 70 to 80% of breast cancer is sporadic. That means they are BRCA negative. And so even if the family history does not point towards any significant history, we must, whenever there's a lump present, we must always rule out cancer. Although we know that 70 to 80% of the lumps are going to be benign, but we are going to call it benign only when proven that it is not cancer. Only then will we be calling it a benign lump. So whom do we offer genetic screening? Breast, colorectal, or endometrial cancer diagnosed before age 50, bilateral breast cancers, 2 primary breast cancers or clustering of breast and ovarian cancer, multiple cancers at a younger age, rare cancers presenting at any age, a family history of male breast cancer. The US Task Force guidelines state that high-risk individuals who have a personal or family history of breast or ovarian cancers at a young age, less than 50 years, which suggests inherited cancer susceptibility, should be offered genetic screening. So I think Dr. Rohit has so beautifully told us about how we have to go about prevention, which is better than cure, with diet, weight management, and great physical activity. We are all aware of the red flag signs of breast cancer, the most common being a lump or a thickening in the breast, which is mostly painless, discharge or bleeding through the nipple, changes in the size or contours of the breast, changes in color or appearance of the areola, redness or pitting of the skin over the breast like peau d'orange. So now, when we talked about the triple assessment algorithm, we talked about clinical examination, we talked about the imaging modalities, and now we come to the types of biopsies. Well, FNAC, true cut biopsies, and excisional biopsies are what is usually talked about. Let us just see what each one has to say. What are the indications of a breast biopsy? So a biopsy is indicated in any patient with a complex cyst, a solid mass, an indeterminate or suspicious solid mass, indeterminate or suspicious microcalcifications, and suspicious architectural distortion. What are the contraindications of a breast biopsy? When there is non-visualization of the lesion, or the overlying skin has infection, or whenever the patient has chances of excessive bleeding because of some bleeding disorders, then we will not be doing, these will be the contraindications of a breast biopsy. So we just talked about these various types of biopsies. A stereotactic biopsy is one which is done under mammography guidance, and a vacuum-assisted biopsy, VAB as they call it. There's a new machine which is available now today, which through a very simple stab incision, you can remove small fibroadenomas and which can be sent for biopsies. So now a breast biopsy, who should be performing it? It should be performed by a physician who understands the technology in the machine, the physics which is used to produce an image, limitations of the technology, as well as common artifacts associated with breast imaging. Additionally, the physicians and technicians must demonstrate knowledge of the breast anatomy and be able to recognize physiological breast changes and common breast pathologies. So friends, we as gynecologists are really not so aware of all these points. And so are we really ready to take a breast biopsy? Well, I think if the lump is a superficial lump, then we can definitely do it. If it is of a significant size, we can definitely do it. Now, what about the FNAC? Once upon a time, everybody used to do FNACs. Now, suddenly, why are we talking about the core needle biopsy? The FNAC can be performed blindly in large lesions or under the ultrasound, mammographic, or MRI guidance in smaller ones. A 21 gauge or a 27 to a 27 gauge beveled needle of variable length is placed into the target lesion in a to and fro motion. The needle can be attached to a small syringe, 2 ml to 20 ml. A slight negative pressure is applied to the syringe to assist in sample collection. Now, the aspirate sample is to be placed on a slide and immediately evaluated by cytopathological or technology for sample adequacy. But friends, we all know that today, whenever a biopsy is taken, not only do we want to know whether it is malignant or not, but if it is malignant, we want to know its ER-PR status, HER2-neu status, so many other newer modalities. All these newer molecular diagnostics are available. All this is not possible with an FNEC, and hence today this device, this particular technology has a limited role in diagnosis, in breast cancer diagnosis. And hence, we have moved ahead with the core needle biopsy. This is the device which is usually used for a core needle biopsy. How do we go about it? We localize the lump, a little bit of local anesthesia is given, a small nick is taken with an 11 number blade. We load the device, place the device at the level of the nick, fire it, withdraw it, remove the sliver of tissue, and at least take 3 slivers from different angles. This is our surgeon who will be just demonstrating a little bit. So this is how the device is. These are the plungers. And we have to understand that both the plungers have to be loaded completely. Now, this is a loaded device. There are 2 firing areas. One is on the side, one is at the bottom. So wherever you are comfortable with, you can do it. And that is this area at the top. This is where the sliver of tissue is going to come, and you're going to remove the sliver of tissue from here. So now this is a lady with a very superficial lump, and for demonstration purpose, we are taking a biopsy, a core needle biopsy from this particular spot. As you see, there is painting and draping that has been done. You could hear the sound of the monitor. So we always connect our patient to a monitor. Local anesthesia is given at the particular point, and with a small stab incision is made. And then this is how the device is fired. Once the device is fired, only the front plunger is depressed, and the sliver of tissue, which is not visible here, unfortunately, is removed. So this is how a core needle biopsy is done. This is especially when the lump is superficial, it is large. You just have to locate it, stabilize it, and it will take at least 2 or 3 slivers from different angles. Not difficult at all. What is very important to remember is that the imaging process has to be done before you take a biopsy. And why is this so? This is essentially because once you take a biopsy, there can be ecchymosis, there can be bleeding, there can be a little bit of distortion, which can, change the findings at mammography. And so it is always going to be mammography and ultrasound followed by a core needle biopsy. Yeah. So we had this BreastCon conference on 30th of July, wherein one of the most important parts was the core needle biopsy, which was the highlight of this particular event. And as we said, it was for the first time where we held it for all our gynecologists. This is Dr. Kopikar, which is a very senior breast surgeon. Here you can visualize that, there was chicken tissue inside which they had kept cysts or small lumps. And under ultrasound guidance, we were guiding our all the delegates, all the students to take a biopsy as to how exactly it has to be done. We are indeed wanting to hold these hands-on core needle biopsy workshops all across the country. And we hope that in the new year, we can be in one of the cities of Kasoga and have this particular hands-on workshop also. What are the complications of the core needle biopsy? Well, it is usually very well tolerated. Skin bruising, hematoma, and biopsy marker migration are the most common complications that can occur. Implants, if they're present, they can get ruptured. The rarest and most severe complications are hemothorax, pneumothorax, and hemopneumothorax. Well, these rare complications can generally be avoided if a trained person is doing the particular biopsy. And all breast biopsy patients should be briefly monitored for complications. So, of course, we will not be doing this procedure unless we are trained in it. We can always have a surgeon by our side. And if it's a very superficial lump, then it is definitely not difficult at all. We can start trying it for our diagnosed fibroadenomas. We can, wherein you remove a sliver and send it, especially when the patient is a little worried about whether this is a malignant mass. And this is how we can start doing our core needle biopsies. Friends, in conclusion, a stitch in time saves 9. Early diagnosis of breast cancer will go a long way in improving the quality and duration of a woman's life. Self-breast examination, clinical breast examination, and mammography are the 3 pillars of screening for breast cancer. MRI is to be used in high-risk patients. The gynecologist is the first point of contact for most women, and we must be well-versed with handling breast health issues. Thank you so much for giving me this opportunity. Thank you, Dr. Lalita. Thank you, Kasoga. And it was indeed a pleasure being a part of this particular webinar. Thank you so much.
Thank you very much, ma'am, for an informative talk. As usual, we enjoyed your talk very much. Now I request Rajashri madam to say a few words.
Yeah, Dr. Charulata Bapat, your vision of having a workshop in all the cities across the country is quite ambitious and a practical way to go ahead whenever there is a lump or suspicion of having a lump in the breast tissue, because quite often we find that it has happened with me last year that a friend's wife with a suspicion of lump was sent across for histopathology, that is the biopsy. It turned out to be normal, but surprisingly within 6 months she had a malignancy, and she had a stage 3 malignancy. So such is the relevance of the diagnosis that we solely depend upon to formulate our line of management, because this is where is going to tell us whether to take or the right or the left. So definitely we appreciate very much your talk, your vision, your information, and it has been quite interesting to know the various aspects of doing the biopsy for the female breast. Thank you so much.
Thank you. Thank you very much.
Yeah, the session is actually open for questions. And I saw one question in the chat box to Dr. Rohit. Should zero biorides be taken as inconclusive or not sufficient reporting? Dr. Rohit, please.
Yeah, I've replied. Thank you for the question, sir. So it means that the evaluation is incomplete. Means whatever modality is being used for evaluating for that patient, that is not sufficient. So bioride 0 means it is improperly evaluated. It needs further evaluation.
Yeah, thank you, sir. And any questions directly also you can unmute and you can ask.
I think it's been a very engrossing session for 1.5 hour.
Yes, ma'am.
Yes.
It's a new thing.
All points very well clarified.
Yes, ma'am.
Made it simple and easy to understand as well.
Thank you.
And let us strive towards having more women with cancer-free state of the breast, especially, because that is on the rise. Definitely.
Definitely, ma'am. We need more and more of the breast workshops.
And such a scary statement that 50% mortality, that is 1 in 2 women die, is something which we can work towards.
Yes, ma'am.
Dr. Rajashri, I had sent an article to Arun to load on the website Kasoga in Kannada.
Okay.
I think this is month of awareness, as Dr.
Yes.
Madam. I had sent it.
We shall pursue and see that it is uploaded.
I also want to take this opportunity to thank all the societies of POXI for having participated in our breast cancer awareness activity in such a large way. I think this was the first time where we organized a pan-India breast cancer awareness walkathon, and I think Lalita has done a great job. Yes. And we have close to 35 societies all across the country who have participated in this. So, Dr. Rohit, we as gynecologists are taking part the cause of breast cancer awareness in a big way. And it is really a proud privilege to be the chairperson of this particular committee, because indeed there is so much work to do, but we have such amazing helping hands all across the country. that it was a big success, this particular walkathon, and we'll keep having them again and again. So,
Yeah,
thank
I
you
think
very
the whole India was looking pink from
much. Yes.
distance. So it was so much because of you, ma'am.
That was really good.
Keep doing that good work, ma'am.
Congratulations for that.
Thank you. It was a big event for us, a really big event.
Yes, ma'am. I now request Dr. Suman Gaddi to say a few words, to comment.
Ma'am, if I can say a few. Hello, ma'am.
Sure, sir. Go ahead.
Yeah, nothing, ma'am. I just wanted to thank the society and really appreciate the effort that has been put up by Foxy. In fact, two largest societies, if I can talk about, if anybody can ask, it's Foxy and Association of Surgeons of India. These are the biggest societies of clinicians apart from the IMA. And it's very heartening to see that such an effort has been made by Foxy at national level and things that to promote breast health. In fact, actually, we would be very happy. I'm speaking on behalf of Association of Breast Surgeons of India as well. We would be very happy to partner of any such programs or the ultrasound workshop, which we also do in our part of it, to take it to a collaboration. And since as we all know that you are gynecologists are usually the first point of contact to most of the women. I think you make a lot of difference than what surgeons or anybody one of us can make.
Yeah, that is so encouraging, and that is such a great thing, because I just want to share this experience that unfortunately, when we were having it in Pune, we met with so much resistance. Believe me, like they said that we have undergone so much training, and who are you gynecologists to just decide to take up breast biopsy? But I think that, knowledge is free for all, and we are doing it for a good cause.
Yeah.
And I think, the more you teach, the more you learn yourself.
Yeah.
So I think let us stop becoming insecure, and nobody's here to, grab anybody's work. And so, Dr. Rohit, your words are really very encouraging. And I shall definitely stay in touch with you so that we can organize a combined CME for all our gynecologists on a bigger scale in the coming months.
Sure. I'd also like to, just mention about Dr. Veena Bhatt, ma'am. I am from her place where she was practicing is very well known. Everybody in our place just talks about her as a obstetrician. She's the only one who everybody used to spoke for last 30 years.
Wow.
Way back in Bhadravati. The other person who I actually met was Suman Gaddi, ma'am. She is my teacher in undergraduate. I don't know if ma'am remembers me. I was not so popular at that time as well. So it was nice seeing you, ma'am, as well. Thank you, Kasoga, for this wonderful opportunity.
Yeah. It is
Thank you, Dr.
multidisciplinary.
Rohit.
Yes, ma'am.
Thank you.
It is multidisciplinary approach. I think even gynecologists, surgeons put together, we fall short of hands to wipe the tears of women with breast cancer.
Yeah.
I think even that will not be enough.
Yeah.
So let's work with that approach. Thank you so much, sir. And thank you, ma'am, Charu ma'am.
Thank you.
For a wonderful
Thank you.
talk and putting us that thought that we can do core-natal biopsy and we should do it. We should not just leave it to surgeons, and there is so much of work that needs to be done in the society.
That's right.
Yeah, now I request Dr. Suman, ma'am, if she is.
I think she's not there. You can conclude the session.
Yes, ma'am.
Yeah.
Yes, ma'am. Rajashri, ma'am, shall we conclude now?
Yes, please. Go ahead.
Now, I now request to present vote of thanks to Dr. Shipra.
Okay, thank you, Dr. Lalita. We really thank our speakers who, despite their busy schedule, have adjusted their time for our webinar. I thank Rohit sir for touching the basic topics, the basics of life, and also Charulata madam for teaching us how to do core-natal biopsy, which we should be starting to do now. I thank Hirimet sir for his usual constant support, Vidya Thobi madam for encouraging us, and Rakshi madam for really attending the webinar and taking so much of interest in it and getting engrossed in it, and also to encourage us to continue to do further good. And I also thank the zonal coordinators as well as the chairpersons of the committees of Kasoga, the presidents and secretaries of the societies of Kasoga. I thank all the wonderful audience and the participants who attended this webinar and made it successful. Thank you all. Thank you so much.
Thank you.
So much.
Thank you.
Thank you all.
Thank you.
See you
Thank you,
again on
Dr.
the
Shipra.
platform.
Thank
Uh,
you, sir. Nice to
Dr.
see you.
Rajeshri, ma'am,
Yes.
actually, Dr. Sonia here. I've already put it in the chat box that we are all set for the workshop. I think we
Exactly.
should really go ahead with guidance of Dr. Charu and Lalita, ma'am.
Yes, ma'am.
I think we should take it forward
Yes, ma'am.
as
We
early as
should,
possible.
with your positive encouragement and support, as usual. I know you'll support me. So we shall do it, madam, together.
At the earliest.
Yeah.
Okay,
Yeah,
ma'am.
Sonia, you're registered as Dr. Mohan, so we couldn't.
Oh, no, actually, I logged out from my laptop, ma'am.
Okay.
And that's why this is
Yeah,
another
good to
phone.
see you there till the end. And recently, I think Mysore had a very good walkathon on breast awareness.
Yes,
So,
yes, ma'am.
wonderful.
Yes, ma'am.
session done.
And the super duper hit, and awareness definitely has made a lot of difference.
Good.
And we are conducting workshops also.
Good.
Yes, ma'am.
Yes, ma'am.
Thank you. Thank you so
Thank
much,
you.
ma'am.
Good night, everybody.
Good night,
Thank you.
everybody.
Bye, Dr. Charu.
Yes, ma'am.
Yeah,
Good night.
good night. Dr. Rohit.